I will perhaps be the one that will convey a more depressing perspective around vaccinations. And I will focus on actually the midterm and the long-term scenarios that the world will be looking at. And I know that there's some interest in Singapore's experience, but I actually would shy away from talking about Singapore's experience unless there are specific questions around it. Because I think throughout the pandemic, we have seen how different countries have responded differently, as Malcolm have talked about it, with different outcomes. And all of this are linked to contextual differences, be it linked to cultural differences, technical capabilities, even the people's trust in their own government. All of this differ, definitely in financial capabilities as well. So I think if I speak specifically about Singapore's experience, it may provide an additional data point, but that data point may not be transferable to various countries' own version of the situation on the ground. But when I think about vaccination, I think it's important to first start off with that this definition of vaccination is unequal to begin with. Because when we talk about vaccines, right now there are 7 vaccines that are under the WHO emergency use listing. And of course, these 7 vaccines have been recognized and used in many parts of the world. But there remains vaccines that are not recognized by WHO yet, including Russia's vaccine, India's Covaxin. And there are tens or hundreds of millions of people that are vaccinated with these vaccines. So I want everyone to first remember that when we think about vaccines, which vaccines alone is already an unequal playing ground. The next is really the ability to buy and access specific vaccines. For example, the mRNA vaccines are a lot more expensive than some of the other vaccines under the WHO EUL. And the price difference could be in order of 6 to 10 times different when we think about the mRNA vaccines compared to the other vaccines. So already when we start thinking about vaccinating countries, vaccinating the world, there will be advanced economies that will be using specific vaccines compared to the rest of the other countries in the world. The majority of the countries in the world, will they be able to afford some of these mRNA vaccines, which present data suggests that the mRNA vaccines appear to be better at protecting against infections, against severe disease, against deaths, even for the Delta, Alpha, Beta, Gamma variants. So that's another unequal playing ground. The third is really in terms of the policy variations that we start to see. Some countries, many countries right now have a policy of universal access to the vaccines. So they have people in the population, as long as they're above 12 years old, 15 years old, 18 years old, they're allowed to access the vaccines. But I would like to remind everyone that many countries in Asia Pacific, including Nepal, many Southeast Asian countries, they still have a national policies where vaccines are only available to 1, 2, maybe 3 vulnerable or high-risk groups in their countries, let alone start thinking about boosters. So in terms of the policy, countries are forced to take different policy decisions because they may not have sufficient access, as what Malcolm and EK has talked about. And finally, it's really around distribution, because we could see that there are many countries that have universal access to vaccines, which means people above 12, 15, 18 years old are able to access the vaccines. Most of these policies are based on equality, but the implementation that EK talked about earlier on really drives a lot of the local distribution, the ground access to the vaccine, and those drives the inequities that we're starting to see. Just for a simple example, even till today, there are many countries that have mega vaccination centers that are based in the cities. That alone, even though you have an equality-based policy for access to vaccination, COVID-19 vaccines, just the distribution, the implementation of this policy drives the inequity, because there are people living in the rural parts of the country that will have a very high barrier to access these vaccines in the cities. So I thought that's just a starting point that I wanted to mention, the unequal playing ground that we attach simply to this phrase, vaccinating the world or vaccinating a country. I talk about the implementation challenges for large countries. This is magnified even more for some countries, including Philippines, India, Australia, where the provision of public health, clinical healthcare is often left to the district, the province, or the state jurisdictions. So even though you may have a federal policy, but how this is implemented actually will drive the equity or the inequity that we see. Now, I talk about looking at the midterm and long-term strategy of COVID-19. Many countries now talk about living with COVID-19 or treating COVID-19 as an endemic disease. What does that actually mean for countries and for the world? Because fundamentally, this relies on the concept of natural immunity from exposure and infection. But we layer on top of this the vaccines because it makes this natural exposure and infection a lot safer by protecting against the severe disease and the deaths. So we believe the answer out of this COVID-19 problem is going to be a prudent mix of vaccination, boosters, and natural infection. You need to have all three coming in to protect a population. It's not just the vaccine, it's not just the boosters. But when we start to look at it this way, vulnerable segments of the population, even when they are vaccinated, fully boosted, vulnerable segments of the population will experience disease and deaths. So when restrictions, you actually start to lift restrictions in countries such as Singapore, Australia, New Zealand, potentially even China, there is going to be a real risk of infection to people in the country. I always communicate that over the next 12 to 18 months, as countries lift this restriction, it's practically a certainty that everyone that is moving about in densely populated cities and communities will be infected. And you need the vaccination to come in to protect. But it will not be enough because health systems will come under considerable strain. This strain will be even greater in what we call COVID-naive countries and cities. Singapore, Australia, New Zealand, Vietnam, Thailand, these are all countries that have done exceptionally well in the beginning of the pandemic, protecting its people from COVID. But it meant that we now have a population where natural infection or the exposure is actually very rare. So when we start to lift our restrictions, even when the population is well vaccinated, you will see a significant impact on the hospitals and the healthcare systems. Deaths will go up. And I think this is the part where politicians, public health practitioners needs to have that public communications, the very frank dialogues to have with the population, with the public, to let them know what is going to come ahead. And what is coming ahead is also going to be this vaccine differentiated measures that we are starting to see, not just happening locally, domestically, but internationally and globally. Because when we start to say that people who are vaccinated, you're welcome to come to my country for business, for leisure, it is a form of segregation on the basis of vaccination. I suspect this is likely to stay even on our ability to board a plane. We may now need to show our vaccination status for certain airlines. Now, what will this drive? This will drive the global inequity that we've often been talking about for COVID-19. And this inequity is not just to vaccines and therapeutics like dexamethasone, remdesivir. Right now, the most recent is molnupiravir. The inequity will actually perpetuate. And in my opinion, I mentioned that it's depressing because I think it is going to be extremely difficult to ever be addressed. Because if we think about it, there is nothing special about COVID-19. It is a major global public health problem, but it is just another public health issue like malaria, HIV/AIDS, TB, antimicrobial resistance. These are all the conditions that we have seen happen, especially antimicrobial resistance. It's a big problem that the world continues to face with or without COVID-19. And we haven't had solutions to this. When we think about access to human papilloma vaccines, HPV, human papilloma virus vaccines, or even the MMR vaccines, we already see this inequity happening in the world, where fragile, frail, underperforming health systems, often in low, middle income countries, they continue to struggle to provide for their populations for some of these things that we talk about for many years. Now let's put on top of this COVID-19 vaccines and treatments. And the same issues that we talk about, primary care strengthening, improving the distribution networks for health services, including childhood vaccination, nutrition meal programs. All of this remains. COVID-19 will just be another global public health problem that the world needs to come together, which will further fragment inequity. This is really the bit where the government overseas development aid will come in to have to necessarily help in this space. The international NGOs will continue to help. But I think as we move on to the Q&A later on, I just want all of us to think about one aspect, which is what is the impact of global movement of people, particularly from advanced economies to poorly vaccinated countries? Would it be ethical? Because I would be well vaccinated, perhaps with very powerful mRNA vaccines. I may be going to a low and middle income countries where the people do not even have access to the vaccines. I may be asymptomatically infected. I bring the virus over. These are some of the ethical issues that we would need to think about and discuss for the long-term strategy.